Welcome everyone that is joining. If you would be so kind to share your name, organization, and your role in the organization in the chat box. We will begin shortly, and housekeeping items. We just want to make sure everyone knows that this is in webinar format. You will only see the panelists on screen. The participants will not be in view. And also this maternal and infant health series today, the Zoom webinar will be recorded. Thank you. I see Megan has joined us. Zora is here with us, and we have several people connecting. Welcome. You see Tracy locally here from Mothers First. Welcome, everyone. We have Stacy from Toledo, Ohio. Wonderful. From Wernet Center Advocacy. Wonderful. Thank you, Rochelle. If everyone can just keep that coming in the chat, your name, your organization, and your role. And I will begin with a brief introduction about Wayside Recovery. Again, we welcome you to the Maternal and Infant Health Series featuring Dr. Veronica Gillispie-Bell. Our topic today will be Black providers and better outcomes. Our agenda will be a brief overview of Wayside. We would like to thank our sponsors for this wonderful series, and that would be the Minnesota Department of Health and Human Services. We will have Dr. Gillispie-Bell make her presentation, and then we will have time for a brief Q&A at the end. Those of you who may not be familiar with Wayside Recovery Center, we provide gender-specific care because understanding the needs of women is critical to optimizing prevention and treatment. Wayside has been in existence for over 60 years, and we specialize in empowering women and breaking generation cycles of substance abuse. As a federally certified community behavioral and health clinic, Wayside now provides services to address whole health that are more affordable and more accessible. Wayside Recovery Center is hosting this Project ECHO, which is an ECHO stands for Extension Community Healthcare Outcome Series, in partnership again with Minnesota Department of Human Services, focusing on reducing maternal and infant health disparities. This series will continue into March of 2022. At this time, I would like to introduce you to Dr. Gillispie-Bell by reading her bio. Dr. Gillispie-Bell is a board-certified obstetrician and gynecologist and an associate professor of Osner Health in New Orleans, Louisiana. She serves as the senior site lead and section head of obstetrics and gynecology at Osner Kenner. Additionally, she serves as the minimally invasive center for the treatment of uterine fibroids. She's earned her medical degree from Meharry Medical College and completed her residency training at Osner Health System. She has a Master of Applied Science in Patient Safety and Healthcare Quality from the Johns Hopkins Bloomberg School of Public Health. Additionally, she has received certification in diversity and inclusion from Cornell University. And clinically, in addition to providing obstetric care, Dr. Gillispie-Bell performs advanced laparoscopic and robotic-assisted laparoscopic procedures and is known nationally for her expertise in management of heavy menstrual bleeding associated with fibroids. Dr. Gillispie-Bell is also the medical director of the Louisiana Perinatal Quality Collaborative and Pregnancy Associated Mortality Review for the Louisiana Department of Health. In this role, she leads initiatives in the state of Louisiana to improve birth outcomes for all birthing persons in Louisiana and eliminate the Black and white disparity gap. Dr. Bell has testified before Congress and led congressional briefings to inform on the drivers of maternal mortality and legislative policy to improve maternal mortality and eliminate, She serves in several leadership roles promoting efforts to achieve health and equity. She has served in several local and national leadership roles and received many accolades for her clinical, academic, and community service contribution. I would like to bring you Dr. Veronica Gillispie-Bell. Thank you.
Thank you so much, Nicole. Thank you all for allowing me to be here with you today. I apologize in advance. I am at the hospital where we are still recovering from Hurricane Ida, and for whatever reason, they've decided to repair whatever is sitting above me in my office. So I'm hearing a drill in the background. Hopefully it won't disrupt us too much. Today, I'm going to be talking to you about Black providers' better outcomes. I have no financial disclosures related to the content of what we're going to be talking about today. And today, I hope that we can describe and discuss what health equity is, some definitions related to health equity, talk about how health disparities occur, talk about implicit bias and structural racism as at the root of those things, and then most importantly, talk about what is that pathway for change. So the first thing that I would like to mention and to highlight and kind of elevate is that we cannot have quality of care for anyone if we are not also focused on equity. And it's taken a lot of those in the quality world some time to realize this. But this slide here is really emphasizing what has been done through the Institute of Medicine. So the Institute of Medicine says that quality is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. They first said, well, there's 5 domains that lead to quality. Care must be safe, it has to be effective, it has to be patient-centered, it has to be timely, it has to be efficient. They later came back and realized, well, you need to have equity there if you're going to get to quality. They came back finally and understood and said that, well, you really cannot have any of these domains if you do not also have equity woven into them. You cannot have safe care if it's not equitable. You can't have effective care if it's not equitable. Patient-centered care if it's not equitable. And so again, in the quality world, we are now recognizing that equity has to be in that conversation if we're talking about getting good quality care. And health disparities are the way that we measure, it is the health outcome that we measure to determine if we are getting to equity. And we're going to talk in a minute about the health disparities that we see in the United States. And so then I will put the question out to you, if we see these disparities, what does this mean about our equity? Just as a reminder that we're not talking about equal care when we're talking about equitable care. When we talk about equality and equal care, that means giving everybody the same care. And so if we look at this picture that I really love by Angus McGuire, you can see on the left side, all of these individuals are getting the exact same resource. They are getting equal care. But for one individual, that's way too much of a resource. For the next individual, that's just enough. And for this third individual, he has the same resource as everybody else, but that's not enough to get him to that outcome. What we want to do is make sure we are giving everybody the same quality of care. So you see on the right, now we see everybody getting basically the resource that they need to get to that outcome. Now for us, that outcome is good health care and good health outcomes. In this diagram is overcoming watching the baseball game and being able to see over the fence. But in that same spirit, understanding that equal care is not equitable care. And again, equitable care is making sure that we have the same quality of care. And what we want to see when we look at our health outcomes is that we want to see that Black-white disparity gap start to narrow. And just another plug here, you don't know what you don't know. So this slide also emphasizes the fact that when we're looking at outcomes, we can't look at the overall number. We have to break down our outcomes into race and ethnicity to know if we are providing equitable care. Just as an example, if we look here at the very bottom of the screen, this is looking at breast cancer mortality from 1990 to 2005 in Chicago. If you look at that bottom line, you would say, wow, we have really improved our breast cancer mortality. We dropped it from about 20% to whatever number that is, about 15%, a 5% difference over a 15-year time frame. That's great. But when we really break that down and we look at it by race and ethnicity, you can see there's very little change for Black women. And so again, it's important if we're going to see what our outcomes are and want to understand if we're providing equitable care, we really want to have this broken down into looking at race and ethnicity. So I already mentioned that health outcomes and health disparities are the way that we know that we're providing equitable care. So if we look across the United States, what does our data show? Well, we see that nationally, Black women are 4 times more likely to die from a pregnancy-related mortality or experience a pregnancy-related mortality. Meaning, we say pregnancy-related, meaning they're dying from a condition that is related to the pregnancy. 4 times more likely. This is the national number. So that means there are places, for example, in New York, where that rate is 12 Black women die at a rate of every 1 white woman. But we see that disparity pretty consistently no matter what state we look at. If we're looking at infant outcomes, the rate of preterm birth among Black women is 50% higher than that of white women. If we look at infant mortality, that rate is 2.3 times higher for Black women compared to non-Latino white infants. And then if we look at severe maternal morbidity, and I think this is always important when I'm doing this talk for broad groups, because we think about socioeconomic factors and how that will also play into our outcomes, and we'll talk about that. But when we look at severe maternal morbidity, the severe maternal morbidity for a Black woman with a college degree is twice that of a white woman with an 8th grade education. So when we have accounted for socioeconomic, we have accounted for education, we've accounted for all those things, we as Black women are still having worse outcomes. And so why is that? Why do we have inequitable care and why do we have these disparities? Well, there's something in the quality world called the Donovan Model for quality of care. So this Donovan Model came about many years ago, where we can say that our structures drive our processes and our processes drive our outcomes. You can apply this to any aspect of quality. Your structure is your physical and organizational characteristics within healthcare. Your processes are how you actually deliver care. And then your outcome is the effect on patients or a population. So we've already mentioned that when we talk about equity, that is a quality issue. So we can apply this same model to looking at equity. So our structures are going to be thinking about structural racism within healthcare and outside of healthcare, thinking about those structures that have caused Black and brown individuals to have poor social determinants of health, things that we know like residential racial segregation. When we talk about processes, we're talking about the way that we deliver care. So health care disparities, different than health disparities, because that's the outcome, but the differences in how we deliver care. And then finally, our outcome are our health disparities, because remember, this is our measure of equity. So we talk about structural racism, and I'm going to focus on just in healthcare and in the institution. But when we talk about structural racism, also known as institutional or systemic racism, we're talking about systems in which public policies, institutional practices, cultural representatives, and other norms work in various, and this is the key part, reinforcing ways to perpetuate racial group inequity. So well, again, those systems, those policies, those things that are how we work basically in the healthcare system, and how they are reinforcing to continue these systems that cause oppression. So just a few to think about. So because we're talking about thinking about Black providers' better outcomes. So if we think about providers and we think about that as a system. So this was from a survey done through the Association of Medical Colleges, the American Association of Medical Colleges, the AAMC. They surveyed all active physicians in 2018. It was about 42,000 active physicians. Blacks accounted for only 5% of active physicians, Hispanics 5.8%, and males were made up 64% of those physicians. So again, if we think about that and we think about that structure, and we think about the structures that it takes to get into medicine, we think about the standardized testing, we think about how the expense of doing interviews, of taking the MCAT, of doing the prep courses for MCAT, we certainly have structures within our educational system that are leading to, that are one of the many obstacles leading to the lack of diversity amongst our providers. In a minute, we'll talk about how that actually then affects the patients. So if we think about, again, from a different perspective, let's talk about leadership. And this I'm just looking at from a gender standpoint. Is the racial diversity in leadership is very similar to what we see in physicians, in the practicing physicians. This is a study done at Korn Ferry, and they studied about 200 hospitals and health systems. And in that study, 55% reported overlooking women for executive positions because they are women. So if 55% admitted to it, what really is that number? Probably even higher. And almost 80% of the healthcare workforce is made up of women, but only 19% of hospitals are led by women, and only 4% of healthcare companies have a female CEO. So if we're not having that diversity, that gender diversity in our leadership, what happens? Then you start seeing, we've now continued a system that is perpetuating. If we have mostly men, they choose men, and that system continues, and it gets very difficult to then have women as leaders. And so we miss that diversity in there. And if we think about diversity and why it matters, in addition to the fact that when we bring in diverse thinking, we bring in diverse minds, diverse backgrounds, we have such a greater power to think about how to attack problems, attack issues. There's data that shows that the greater the diversity you have in your workforce, in your leadership, the stronger your ability is as an organization to reach your organizational goals. Because if we're all thinking the same way and we're all doing the same thing, then we can address all of the issues, the problems, and relate to everyone that we need to relate to. In addition to that, from a leadership standpoint, we know that having diverse providers leads to improved outcomes. So students are trained at diverse schools, medical schools, are more comfortable treating patients from a wide range of ethnic backgrounds. They're more culturally competent. And when physicians are the same race as patients, patients report a higher level of trust and satisfaction. Now, that's not to say that I, as a Black physician, cannot take care of white individuals and they don't have trust. That doesn't mean that. But there is just a level of trust when you see somebody that looks like you. We also know, I didn't put it on the slide, study that was done by Rachel Hardiman down in Florida, that when there was concordance of race between the physician and the family for neonates, there was improved infant mortality for those NICU babies as well. And then Black, Latino, Native American physicians are much more likely to practice in underserved areas and more likely to accept patients with Medicaid. Now, we didn't even go through the Native American population in those physicians of active providers that we were looking at earlier, but that number is even less. So if we don't have that diversity of physicians in our healthcare workforce, who is serving these patients? Who is serving those underserved patients? Who is serving those Medicaid patients? And again, who can patients look at that looks like them? Now, we talked about some of those structures, but now let's talk about the processes. And again, if we think about our model, structure, process that produces our outcomes, processes are how we deliver care. So healthcare disparities. And just to point out, and I mentioned this, that there's a difference between health disparities and healthcare disparities. Health disparities are those outcomes, those measures that we were looking at before: infant mortality, preterm birth, maternal mortality. Healthcare disparities are the differences in how we deliver care. And I'm going to show you just some examples. So Black individuals are less likely to be offered preventive services such as cancer screening and influenza vaccine. We know it's flu season. Everybody is supposed to get a flu shot. So why is it that Black individuals are less likely to even be offered the flu shot? I recently did an interview about the COVID-19 vaccine. We know that our rates of COVID-19 vaccine in the pregnant population is low. It's only about 30%. It's half of that for Black pregnant individuals. And I was asked in this interview, well, why is that? And I mentioned, in addition to the distrust that Black individuals have with the healthcare system, and let's not forget about our historical perspective, the Tuskegee experiment and research that has been done on Black individuals in just a terrible and unethical way. In addition to that, I'm not so sure that Black pregnant individuals are offered the COVID-19 vaccine at the same rate as their white counterparts. We know that Black individuals are less likely to have adequate treatment of their pain. Black and Latino individuals are less likely to receive bypass surgery, even when medically indicated. And then women are less likely to undergo appropriate cardiovascular testing. So all the things that I have laid out here on this slide, these are all standards of care. So why is it that we are not offering and providing this same care for all individuals? And I say it's due to implicit bias. And so we're going to get into this in just a little bit. For any of you that were able to attend the talk that I did about 2 weeks ago through Stratus for Healthy Start, then you will remember some of these same topics and same things that we talked about. So implicit bias is also known as unconscious bias. It is defined as the attitudes or the stereotypes that affect our understanding, our actions, our decisions in an unconscious manner. It's really important to think about that unconscious part. And I think that these pictures juxtaposed to each other are a wonderful but sad illustration of what bias looks like in America. So if you look on the left side of the screen, this is the Black Lives Matter protests, and this is on June 3rd. You can see that this is mostly Black and brown individuals. You can see they are kneeling, they are in a peaceful stance. And how are they met? They are met by police that are in riot gear. On the flip side, on the right side, this is the Capitol takeover on January 6th. And you can see that most of the individuals there were white. And how were they met? They were met with police in just regular uniform. So looking at this, what does this say? This says that as in society in America, that if we see a group of Black people, then they're going to be violent. And so we need to prepare for violence. However, if we see a group of white people, they must be coming with peaceful intention. And again, this speaks to our bias and our bias about Black and white people and other people and just what we feel about those people. And then our actions are in response to what that bias is. Now, before we start taking this out on the police and making and starting to point fingers, I want us to go through an exercise. So I'm going to give you a story, and I want you, there's a question at the end of the story, and I want you to think about what that answer may be. A boy and his father are driving down the road. They get into a car accident, and the father is killed. The boy is taken to the hospital, and it's decided that he needs surgery. The surgeon comes out and says, I cannot operate on him. He is my son. And so the question is, who is the surgeon? So I'll say the question again. So a boy and his father are driving down the road. They get into a car accident. The father is killed and the boy is taken to the hospital. It's determined that he needs surgery, and the surgeon comes out and the surgeon says, I cannot operate on him. He is my son. And the question is, who is the surgeon? So I'm going to give y'all just a minute to think about that. And I was going to say, you can put it in the chat. I see one person has already put it in, someone else. Very good. So the answer, the surgeon is his mother. When I tell y'all the first time somebody told me this, and I was like, well, who is the surgeon? Well, obviously it's a homosexual relationship and he has two fathers, and we need to be understanding that there are all types of relationships. Did not even occur to me that the surgeon could be a woman, that it would be his mother, which is sad to say, because as you heard in the description, most of my clinical practice is doing surgery. I operate every Tuesday. I take out fibroids every single Tuesday, and it just did not occur to me. But that speaks to my exposure and where my bias is. When I hear the word surgeon, I think of man. Now, how does that happen? Well, when we think about how biases are formed, so implicit biases are really a process that our brain has done over time to account for all of the information that's coming in at one time. So we cannot accommodate all of the information that is coming in from all these different areas. So what our brain does is it takes shortcuts so that it can process the information, because we cannot possibly process everything. And the way that we take those shortcuts is we seek out patterns. But those patterns come from experience and social conditioning. So for me, I never saw a female surgeon probably until I was in residency. So my experience and my social conditioning of seeing even a physician, it was a man. So for me, when my shortcut is when I hear surgeon, I think man. And so that's why it did not even come to me immediately that in that story that the surgeon could be his mother. And so we all have biases because we all do this. The problem is, and it's unconscious, the problem is when you are a healthcare provider, those biases affect how you take care of your patients, particularly for Black women. we're gonna go through a little walk through history. And remember, biases are formed by your experience and social conditioning, okay? So if you think about what the social conditioning has been around Black women and Black women throughout history, we then understand how some of this manifests and how providers take care of Black women. So if we look throughout history, there have been 4 archetypes to explain or describe Black women. First, it was Mamie, then it went to Sapphire, then it went to Jezebel, and then it went to the welfare queen. We're gonna take some time to walk through each of these. So Mamie, this was kind of in the antebellum time period, kind of coming out of slavery. But at that time, Black women were stereotyped as being obese, dark skinned, maternal figures, desexualized, loyal to white families. And dark skin was made to seem ugly. And this probably actually came out of slavery, because we know that dark slaves were made to work in the field while light-skinned slaves were allowed to work in the house, creating colorism from the slave owners at that time as a way to control the slaves. And that's probably where this came from. But dark skin, but Black women were seen as dark skin, and that was also equated with being ugly. They were stereotyped as only being domestic workers. This was perpetuated in art, in literature, in media, Aunt Jemima the pancakes, all of those things. And so if you are an individual that has not interacted with Black women, this is where you start to form your stereotype. Out of this stereotype also was that Black women take care of white families' children, but not their own children. And so we know how that manifests today, where Black women, especially single Black women, there is a stereotype or a bias that they are not taking care of their children. Moving on from Mamie, we moved into the Sapphire archetype. And so the Sapphire archetype, and it was named for a character from the Amos and Andy show. And Amos and Andy was a radio show from 1928 to 1960, but then it went on TV from 1951 to 1953. In Amos and Andy, it portrayed Black men as being lazy, confused, unemployed, financially inept. They didn't know how to manage their money. And it portrayed Black women as being aggressive and emasculating. And Sapphire was one of the characters. And so that's why it's called the Sapphire archetype. And so Black women were portrayed as being rude, as being loud, stubborn, overbearing, emasculating to their male partners. And this really led to the angry Black woman stereotype, which then actually becomes a way of controlling Black women because they don't want to fulfill this stereotype. So Black women often remain silent. And we see this time and time again in healthcare, that when Black women speak up, one, their voice is not recognized, but they're not going to push because they don't want to be seen as that angry Black woman. Moving from Sapphire then was the Jezebel archetype. And so this stereotype Black women as being hypersexual, we had mainly where Black women were not seen as sexual at all, but now seen as hypersexual. And this came because Europeans started traveling to Africa. And in Africa, women did not wear as many clothes as European women did. And because the European men sexualized that, that's where this stereotype came from. It was also used to justify slave owners raping slaves. And this was perpetuated in art and novelties and media. Again, that social conditioning of what Black women are. This is just an example. This was from LBJ when he ran for presidency. This was one of his slogans and one of his posters. And you can see I went all the way with LBJ, making fun of Black women and how they talked, or Black individuals and how they talked at that time period. And then that Black women would be loose and sleep with anybody. The next archetype that came was the welfare queen. And this came from the early 1980s when late 1970s when Ronald Reagan was running for president. And he used the story of Linda Taylor during his 1976 campaign. Now, Linda Taylor was a woman who could pass for a lot of different ethnicities. Wasn't really, it wasn't in the media, didn't really say exactly what her ethnicity was, but she could pass for many ethnicities, and so she may or may not have been Black, but she used her wit and she got money off of the welfare system. And from that, Ronald Reagan came up with this term, welfare queen. And so it stereotyped Black women as being uneducated, single mothers who don't take care of their children, who have children just to take advantage of public assistance. And so from that, then David Duke used that platform to recommend giving Black women money, or women on welfare money, to get Norplant, if y'all remember that form of birth control, which the FDA pulled off the market. But it was a 5-year implant for contraception. And so that was that practice of eugenics. And so even though, based on the data, actually more white households participate in welfare programs, this is what was stereotyped, is that Black women are poor, they don't have money, they're on welfare, and they just keep having kids so they can have more money from the welfare system. And so again, this is so important when we think about the healthcare system and how we deliver care and how we have these biased beliefs about Black women and where these come from. Now, moving to another example of bias in medicine, specifically in medicine. If you look at this slide, on the left side of the slide, the man that's standing in a Black coat is Marion Sims. He's known as the father of modern gynecology. He invented the speculum. He invented the procedure to fix vesicovaginal fistulas, but he did all of this by operating on Black slave girls with no pain medication. This was at a time when anesthesia was available, and anesthesia was given to white women when he began doing those surgeries on them. But when he was experimenting, he did not use anesthesia while he was operating on these Black slave girls. And I call them girls because they were as young as 14, 15 years old. What came out of that was the belief that Black individuals do not feel pain in the same way. It actually got into the textbooks. And so to talk about how bias becomes a belief and then it gets practiced in medicine, on the right side, this is a graph from a study that was done at the University of Virginia. They surveyed about 200 white medical students and white residents, and over 50% of them believe that Black individuals do not feel pain in the same way because they have thicker skin, they have nerve endings that are not as long. All of these biased beliefs. For anybody out there, if you don't know, biologically, there is nothing different about Black individuals. We do not have thicker skin. Our pain nerve endings are all the same. But because of this biased belief from back in the slavery period, that became a real belief and is perpetuated in medicine, how we take care of Black individuals. On this graph, the higher the belief that Black individuals don't feel pain in the same way, the less likely those doctors and residents were to prescribe adequate pain medication for Black individuals. Now, the other way we see implicit bias manifest is in microaggressions. And I think these are just that much more damning. These are comments and actions that subtly and often unconsciously or unintentionally express a prejudiced attitude toward a member of a marginalized group, such as a racial or gender minority. So there's three types of microaggressions. We have micro assaults, micro insults, and micro invalidations. And we'll talk about each one of these. So micro assault is a conscious or intentional action or a slur that comes out of an unconscious bias. So just as we showed in the Black Lives Matter movement, when the police were meeting the Black and brown, mostly Black protesters in riot gear, that is a conscious act of, I'm going to put on riot gear because my unconscious belief is that if Black people are gathering in a group, they're going to be violent. So that's an example of a micro assault. A micro insult is a verbal or nonverbal communication that subtly conveys rudeness and insensitivity that is demeaning to a person's race or ethnicity or gender. So for someone to say, which I've heard many times before, well, you don't sound Black, meaning I'm articulate, and so I don't sound Black. So how are Black people supposed to sound? Not articulate. And so that is a verbal communication that is demeaning to my Black race to say that. It's not a compliment. And then we have micro invalidations. These are communications that subtly exclude, negate, or nullify the thoughts, feelings, or experience reality of an individual. So an example for this is we know that during the summer, we had a lot of movements around Stop Asian Hate. Well, for someone to then respond, say, stop all hate. Well, yes, we don't want anybody to experience hate. But in that moment, Asian Americans were afraid. They were afraid for their mothers, their fathers, their grandmothers, grandfathers to walk on the street because they did not know if they were going to have a senseless act of violence that they were going to experience. And so to say stop all hate when others are saying stop Asian hate, you're invalidating what Asian Americans are feeling in that moment. The important part of these microaggressions, when we talk about healthcare and talk about, again, why we experience these disparities and see these disparities, we don't just walk into the hospital and all of a sudden turn these off. So we still have our biases, we still have our microaggressions, and we not only display these to the patients, but we display this to each other. It comes out in how we treat our colleagues, how we treat our employees. And so again, this is how it then starts to affect our disparities. And then when we think about bias and microaggressions and all those things, and talking about getting to equitable care, really equitable care is respectful care. That's really what it is having respect to make sure that we're providing all individuals with good quality of care. And just to think about what respect is. So Jackie Robinson says, I'm not concerned with you liking or disliking me. All I ask is that you respect me as a human being. So it's not about being nice. It's about giving me what I deserve as a human. And then the quote from Lawrence Stern says that respect for ourselves guides our morals, but respect for others guide our manners. So if we are displaying these microaggressions towards other individuals, what does that say about our respect towards them or towards representatives of certain groups? And then respectful care is patient-centered care. That is providing care that is respectful of and responsive to individual patient preferences, their needs and values, and ensuring that patient values guide all clinical decisions. And 8 principles that go around that. That means respecting patients' preferences for how they want their medical care to go. And of course, that has to be done in a shared decision-making model where we are talking about risk and benefits and alternatives, but having respect for a patient's preference, having coordination and integration of care for individuals, having information and education. I hear so many times, but especially with I think patients in general, but particularly Black and Brown patients, they say, well, nobody talked to me. The doctors and nurses were making decisions around me and nobody talked to me. We have to see our patients as informed consumers and inform them of what's going on so that they can make their own informed choice about their care. It's about providing physical comfort, emotional support, having involvement of family and friends. When we walk into a room and we have patients that want to have their other extended family members as part of that conversation, and that when they have to make decisions, to not roll our eyes and acknowledge that and understand that family and friends are important, especially in different cultures, in how decisions are made. Having continuity and transition, and also making sure that individuals have access to care. And then there are pathways to change. I think that, we talked about some very daunting things, especially when we think about bias and how bias affects the difference in how we deliver care, and how some of that is overcome. We do know that some of that is overcome when we have diversity of providers and we have more minority providers, but then we have all those barriers to even have minority providers. But there are pathways to change that we as an American healthcare system can move in a different direction. Now, it really takes a village. It's going to be involving healthcare providers. It is patients and community partners. It's also healthcare systems and then policymakers. And we're going to go through each of these and talk about what role each of these has in making sure we are getting to equitable, respectful care. So for providers, I love this quote from Gandhi that says, "Be the change you want to see in the world. Change starts with me." 60% of providers, this is a study at Harvard, 60% of providers believe that the quality of care is different by race. So majority believe that the quality of care is different by race, but only 40% felt like that applied to them. That can't be the case. We can't have only 40% of the providers saying that patients that they are providing inequitable care, and we know that we have these outcomes. And so it's about we as providers acknowledging that we have biases. We all have biases. I just demonstrated it in the story when I did not come up with the fact that the surgeon was his mother. We all have biases and we have to acknowledge that. One of the ways to do that is to do the implicit association test through Harvard. It's completely free. There are lots of different ways that you can evaluate what your bias is. It could be a gender bias. It could be a racial bias. There's a test in there to see if you have a dark skin, light skin bias, size bias. But it's important to acknowledge that you have a bias so that you can then start to address it. When you're addressing it, you have to remember that this is unconscious, as we talked about. So when you address it, it's like undoing a habit because it is unconscious. And so just like if I was smoking today, here's Wednesday, I'm smoking, and I say, okay, I don't want to smoke anymore. I'm not going to be not smoking by Monday. It's going to take longitudinal and intentional change for me to break that habit. And it's the same way when we address our biases. But when we're doing that, part of that is seeing people as individuals. So seeing Veronica as Veronica and everything that Veronica is, not seeing Veronica, she's a Black woman, so now I've decided that this is what she is. So seeing people as individuals, recognizing that your belief is a stereotype. If you have a belief about Black women that they are angry all the time, understand that that's a stereotype that has historically been put into media to form that narrative. And that's just a stereotype, that's all it is, and that you cannot apply that to all individuals representing a group. You have to increase your opportunity to have contact with individuals from different groups. Again, all of our biases usually our biases are formed from social conditioning and not from personal interaction. And so the more you interact with diverse groups, the more you start to address your biases, understand your biases, and start to think in a different way. And then above all, it's about having empathy, putting yourself in someone else's shoes before you start to point fingers at them. One of the things that I harp on all the time, and I actually think I might have it later in the slide, but I'm gonna say it now, is I do not want to hear any other healthcare provider say that a patient is non-compliant. You do not know what a patient has to go through to see you as a provider, to get their medications, to have follow-up. You don't understand that. And so until we can put ourselves in that patient's shoes and understand what the barriers are for them as individuals to accessing care, to understanding the care, health literacy, then we don't need to say that they are not compliant. We've got to diversify our perinatal workforce. And I mean the workforce across the board, not just amongst physicians, but physicians, nurses, midwives, doulas. So not just diversity by race and ethnicity, but diversity by training. It takes a village. We need all of those areas of the perinatal workforce to relate to our patients in different ways. Patients coming into my office, that there's a level of care that I can give in the office. Patients in their home, when they're in their environment, you have a better understanding of what the social determinants of health are for those individual patients that may make it difficult for them to access or be compliant with care. And so it's important to have that diversity of workforce so that we can think about different ways to deliver care. We also have to think about our patients as partners. We have to keep our patients at the center of the care. It doesn't matter if I have this great innovative idea about I'm going to do X, Y, and Z so that patients can understand better what we're doing to improve hemorrhage and hypertension. If that doesn't resonate with the patient, then I just wasted all of my time. So we need to hear back from our patients, keep them at the center to make sure the work that we are doing and the improvements that we think we're doing are really what they need. Latasha Rouse, who is a patient-centered expert, has this quote that I really like, saying that family-centered care is not something you do for a family, it is something that you do with a family. And we have to think about our healthcare being a partnership. There are tools to measure respectful care, and I encourage healthcare systems, hospitals, different health settings to use these tools. These are 3 validated tools to determine if you're giving respectful care. We know we measure equity and equitable care by health outcomes, but that respect part, these are 3 different ways that you can check for that. Again, we have to think about our patients as partners in decision making. So that means that we have to involve them, that this has to be a partnership. Traditionally, as healthcare providers, we are trained in a prescriptive manner or a very paternalistic manner, that I am the doctor, I went to school, so I have the knowledge, and so I will make the decision for you because I know best. And that's not right, that's not correct, and that's not going to improve our outcomes. We have to share that responsibility. I, as a provider, yes, I do have the knowledge. So it is my responsibility to give you, my patient, the information, my opinion about what is best for you. But we have to make that decision together. I have this all the time. Patients come in with fibroids and we go through the options and they'll say, well, which one's the best? And I always say, well, there is no best. It is what is best for you. I can help you to make a decision, and I have to live with that, whatever that decision and the risk and the benefits that go along with that. But you literally have to live with that decision. So we need to make this decision together because we are in this together. And that is a model that we really have to change in our healthcare system. We have to think about, as leaders, what do we do from a system standpoint to change how we deliver care? We right now really are on a volume-based system in America, and we need to move to a value-based system. When we talk about quality and we talk about quality measures, that should be quality outcomes, and these disparity outcomes should be just as important as the number of patients that a doctor sees, or the number of deliveries that a doctor does, or that a midwife does, or that a doula goes to see or is there for. And so we have to start to value over volume and create those systems of culture and respect and accountability. And part of that value is creating that accountability. For policymakers, they have a huge ability to change the landscape. They have a chance to change those structures that we talked about in the beginning. So we have to review maternal policies through a lens of equity. We have a lot of states that are working to require implicit bias training, which is great because that is a step. But there are also other states that are working to diversify the workforce. Louisiana, we created a doula registry through legislation. And so working on that now to have doulas as a covered service. And I know that y'all have already worked on that, I believe, here in Minnesota, but there are very few states where doulas are a covered service. We know the benefit of doulas in having that other person to be a voice of the patient, and working with providers to provide a team approach to patient care. But in most states, you can only have a doula if you can pay out of pocket. And so working to make sure that that is a covered service. Now, just to talk about my experience in quality, linking quality to equity through our perinatal quality collaborative, and in the hopes that it may give you some ideas of things that you may be able to do to reinforce this idea of quality and equity and how they go together. So the Louisiana Perinatal Quality Collaborative, which is a collaborative of birthing facilities across Louisiana. Right now we have 42 of our birthing facilities as part of the collaborative, 42 of the 47. As part of the collaborative, it's physicians, providers, nurses, community advocates, different individuals that are working to make sure that we are implementing best practices in facilities to improve our maternal outcomes. Now, we launched in 2018. And at that same time, we released as a state our first maternal mortality review report in 10 years. At that time, 10 years. At that time, because it was a quick report, it only focused on pregnancy-related deaths, so deaths related to the pregnancy. And at that time, it was discovered that the leading clinical causes were hemorrhage and hypertension, and that we had a disparity of 4 Black women dying at a rate of every 1 white woman. These numbers have improved since that time, but that was reviewing deaths from 2011 to 2016. So out of that, we came up with our aim, or what our goal was for the Perinatal Quality Collaborative, and it was around reducing maternal morbidity. And our goal was to reduce maternal morbidity by 20% from hemorrhage and hypertension from August 18 to May 2020, Mother's Day 2020, and to narrow the Black-white disparity gap. We were very unique as a state collaborative in that we had a goal to also address disparities. Most states, and even the Alliance for Innovation in Maternal Health that really gives us all of our patient safety bundles, they thought about disparities and equity as a separate thing that you do. And we said, oh, no, it has to be woven into what we do. And so for that, we set that goal. Now, when we help our teams and we're designing our activity, we have what's called a driver diagram. So we believe there's 4 areas that no matter what we're working on in healthcare, that these 4 areas have to be addressed if we're going to get to some improved outcome. We have to have reliable clinical processes. We have to have respectful patient partnership. We have to have effective peer teamwork, and we have to have engaged perinatal leadership. And around that respectful patient partnership is all the things that we've been talking about today. We have to design our care that shows that we have transparent communication for trust, and that we look at our patients as informed consumers. Now, we support our teams through the collaborative by creating a culture of equity. We are always talking about it, and we make it a priority. We started, I've told this story 50,000 times, but we started, like I said, August of 2018. We had our second learning session in October of 2018, where we had all of our birthing facilities, our teams from our birthing facilities come together, and we give them information and we teach. And we made that learning session all about health equity. And so we started the session with just talking about disparities, much of what we talked about today. What is the difference in healthcare disparities and health disparities? What's the difference in equity and equality? This is what I mean by implicit bias. We had 2 of our hospital teams walk out in the middle of the presentation because they felt offended by what we were talking about. So we had to make a decision as a team. Do we back down on talking about equity? Do we maybe take a step back? Is this too much? Or do we realize that this is the right thing to do, and it's the right thing to do for our patients, especially the ones that are having the worst outcomes, and we double down and we keep pushing forward? We decided to double down and keep pushing forward. And I'm happy to say that now all of our teams are working on equity. Those 2 teams did come back into the collaborative, but all of our teams are working on equity and trying to improve what's happening in the hospital, especially for Black and Brown individuals. We do something called a 30, 60, 90-day chat with our teams where we meet with them every quarter. And we go over what their goals are and what their aims are and what they are trying to work on in their hospital towards our big aim. And you can see here from this form, no matter what they are working on, they have to have a patient partnership and equity goal. And then we help them figure out, what can you do in 30 days? What can you do in 60 days? What can you do in 90 days to get to that, to achieving that outcome? And then finally, to further assist our teams in working on this and to congratulate them for the work that they're doing, we have created a birth ready designation, which is just a designation that says these hospitals have gone above and beyond to provide safe, equitable, and dignified births. And there's 5 areas in that, but one of those is addressing health disparities and patient partnerships. So like I said, our hospitals always have to work on that. And it can be working on implicit bias training. It can be mechanisms for patients to provide feedback so that you can use that feedback to lead to tests of change. It can be having patients as part of your improvement team, but regardless, they have to be working on equity. And then in summary, we have to make care respectful to get to quality care so that we can address health disparities. We have to recenter the work to the who and the why. And we have to think about, when we're doing that, making sure that our workforce looks like the patients that we serve, because we know that that leads to better outcomes. And we have to make care equitable by making care better and making it consistent. I'm going to save my story that I had right there because I know I'm running out of time and I want to be able to answer your questions. So I'm going to stop sharing so that I can address any questions that you may have.
Thank you, Dr. Gillispie. What an awesome presentation. So far, please paste your questions in the chat. And we have maybe about 4 minutes for questions. And so Julia was saying, I like what you're saying about non-compliance, since our clients need to have choices with their bodies. I am curious about how you view vaccine mandates.
So that's a tough one. Thank you, Julia, for that question. That's a tough one. So I am not in a position of leadership, thank goodness, that I have to make the mandate. I do understand where the vaccine mandates come from. That has not been my approach in my clinical practice. I do offer the COVID-19 vaccine to all of my patients because it is what is recommended as a best practice. We also know that Black individuals have experienced deaths from COVID-19 at a rate higher than white individuals. Actually, the indigenous population is suffering the worst. We know that pregnant Black individuals that contract COVID-19 have had the worst outcomes as well. And so for me, when I'm talking to patients, I go through the risks, I go through the benefits, I go through the alternatives. I tell my vaccine story. I wasn't getting the vaccine. That was not my plan. But then I did my research and was like, okay, this is safe and it is the right thing to do for me and my family. But I never shame them. I offer myself as a resource for them, just with everything else. The flu vaccine too, I recommend that. Plenty of patients decide they don't want to get it after I go through risk and benefits, and that's their decision, and I support them in that. And I think for that, it helps me to relate to them and for them to have trust in the information that I'm giving. But I do understand, and you're right, that is having the mandate there does make it challenging when we think about patient autonomy.
Wonderful. I did see a question in the chat, and excuse me, in the Q&A, and it was about being able to actually have the slides to share. If you could give us some instruction on that.
Sure, I will, Nicole, I'm going to adjust the slides. I'm going to take out one thing and I will send you a PDF version that you can share with the group.
Wonderful, thank you. Julia's just saying thank you. It's difficult with her own family members who choose not to be vaccinated. We have Rhonda Fellows, who is a local doula here, who's saying thank you. She loved the presentation. We are at 12:59. We want to respect everyone's time. Again, we want to thank our sponsors, DHS, for help sponsoring this event. Dr. Gillispie will be presenting again on November the 10th from 12 to 1 p.m. regarding infant health in COVID-19. I have placed in the chat the series. There are multiple others in the maternal and infant health series. And again, we thank you, Dr. Gillispie, and our thoughts are with you, as we know you are still dealing with so much down in Louisiana. So we are sending you positive energy.
Thank you. I appreciate that. Thank you all so much.
Thank you. Have a great afternoon. And this will conclude our maternal and infant health series. Thank you, everyone. Have a great day.